Hey everyone, today's video is going to be on hiatal and paraesophageal hernias. So we're going to be covering some of the basics of the anatomy and physiology of the diaphragm and the esophagus. We'll go over in detail the four different types of hiatal hernias and then why we care, what the indications are typically for these repairs, both in an elective and an urgent fashion, and then the basic tenets of the repair and really covering some key definitions of things like fundoplications or gastroplasties um, that you might come across and not necessarily understand at first pass. So to start, here's a nice illustration of the diaphragm. And initially, when I first heard about hiatal hernias, I didn't really understand, why do we get hernias in this location so much? I mean, I think we kind of understand groin hernias. That's where a lot of the weight is in the body, and when you're lifting heavy objects, you're getting a lot of abdominal pressure, and you have those weak spots where the inguinal canal is. So it makes sense that we get hernias there. But what about the diaphragm? And well, I didn't understand it at first glance. When we think about the physiology of the diaphragm, this is a really dynamic space with a lot of constant movement, a lot of stuff going on here. So it makes sense that over a whole lifetime of activity, the diaphragms will start to break down. And we do end up seeing these hernias typically in our more elderly patients. So to orient you here, we're looking at the underside of the diaphragm here. So this is the spine going down towards the feet, the patient's head, and everything else is up back here on the other side of the diaphragm. Just getting oriented to the diaphragm itself, we see this outer muscular layer and then this more central tendinous layer. Then we have several openings in the diaphragm called hiatuses, I guess. Hiati. We have one for the vena cava right here, one for the aorta down here, and then the one we're really going to be focused on today is the esophageal hiatus here. That's where our paraesophageal or hiatal hernias occur. And so what's dynamic about this whole area? Well, first, of course, we have the esophagus right here. Think about every meal you've had, every swallow, you're going to have some peristalsis of the esophagus. So that's movement right there. Down here at the aorta, pretty close to the esophagus, this is, of course, constantly beating, right? With every heartbeat, we have movement. The heart itself is just on the other side of the diaphragm, somewhere around here, constantly beating. So every heartbeat, every moment of peristalsis, we're having movement in this area. And then, of course, the entire diaphragm, what's its job? Its whole job is to breathe, right? So every respiration, we have some movement in this area. So it's no wonder as you have respirations, heartbeats, peristalsis, all of this built up over an entire lifetime of activity, there's going to be some wear and tear of this area. And it makes sense that we get some weak spots and some herniations, especially through this esophageal hiatus. And so we will typically get four types. Well, there's just four types of hiatal slash paraesophageal hernias. You'll understand why in just a second. So first, let's just look at our normal anatomy again, this time from more of a front-facing view instead of the axial view we were just looking at. So up here we would have the chest. This is the diaphragm right here. Down here we have the abdomen. So the esophagus runs down through the chest, meets the diaphragm. Right here we have the GE or gastroesophageal junction. And then down here we have the stomach nicely situated in the abdomen, just the way it's supposed to be. So a type 1 or a hiatal hernia is also called a sliding hiatal hernia. And all that is just the stomach in its normal position slides up into the chest. So you see the GE junction used to be here. Now it's moved up here. We have some of the stomach up in the chest where it shouldn't be, and this kind of pinch point of the diaphragm where the GE junction used to be, where the stomach's a little bit squeezed in on itself. But the majority of the body of the stomach is still down here in the abdomen. So that's a type 1. A type 2 paraesophageal hernia, sometimes called a true paraesophageal hernia, because you can see that the GE junction is actually in its normal location down here. But we have paraesophageal herniation of the fundus of the stomach. Remember, the fundus is just this part of the stomach right here. So the fundus of the stomach is present in the chest, and then we still have some of the stomach down here in the abdomen as well. Now we talked about type 1 and type 2. A type 3 is just a combination of type 1 and type 2. So you see the GE junction is here outside of its normal location, so that's slid up. And we also have the fundus of the stomach up here in the chest. So a type 3 is a little bit more common than a type 2. And it just has, again, both of those components of a type 1 and type 2 paraesophageal hernia. Finally, type 4, sometimes these are called giant paraesophageal hernias. And what makes them a type 4 is the inclusion of First of all, we have a type 3. Our gastroesophageal junction is out of place. It's slid up. We have our paraesophageal herniation of the fundus, but we also have other organs. In this case, it looks like they put up a loop of small bowel, but this can also be colon, spleen, any organ that comes in the chest that's not the stomach would make something a type 4 or a giant paraesophageal hernia. And of course, oftentimes you have much more than just this little section of stomach. You'll get often almost the whole stomach up in your chest. But we'll talk a little bit more about that on a later slide. So thinking about numbers here, type 1, just that sliding hernia, that's the most common. That's about 90% of your hiatal hernias. Of these remaining 10% down here, the type 2 through 4, type 3 is your most common. This is 90% of these remaining 10%. And then more rare is the type 2, which is that true paraesophageal, and then type 4, the giant. So why do we care about these? So the most common indications for repair are symptoms. So when we think about having our stomach here, this is my attempt to draw a type 3 hiatal hernia. So we have the G junction sliding up into the chest, and we have this herniated fundus. So you can imagine that this gastroesophageal junction, this lower esophageal sphincter, is not going to be working very well. So we're going to have reflux of gastric contents into the esophagus. So a lot of these patients have pretty significant GERD. They can also have dysphagia and regurgitation because stuff gets built up in this part of the stomach where it's kind of pinched over the diaphragm. You can imagine that these parts of the stomach get kind of pinched together here where it comes through the diaphragm. And when those areas of the stomach rub against each other, so those can form ulceration. That's a classic PIM question. Those are called Cameron's ulcers, and those can lead to GI bleeding and anemia. And then, of course, anytime you have organs out of place, things getting stretched, this can also cause pretty significant pain as well. So I'd say those are the primary symptoms. GERD, where we have the reflux, some dysphagia, regurgitation, anemia from these Cameron's ulcers, and then pain. And then more significantly, we can have complications that would require a more urgent repair. So we already talked about bleeding. That's a common complication from those Cameron's ulcers, but we can also have obstruction and volvulus. And volvulus is really hard to draw, so I just got a picture here. So you can see when the stomach starts to get all the way up in the chest here, it can almost twist on itself. And you can imagine how food would have a really hard time getting into the stomach all the way around here and back out into the duodenum without obstructing and backing up. Of course, if patients are fully obstructed, that's a surgical emergency. Also, this twisting can happen so severely, excuse me, that it cuts off blood supply to the stomach, and then you can have gastric necrosis, and that causes patients to get extremely ill and also requires emergency surgery. So anytime patients are presenting with severe complications, typically obstruction or volvulus, they're going to require an emergency surgery, and that will, like any emergency surgery, have much worse outcomes than an elective repair of these hernias. So that's why we're very eager to repair all symptomatic hernias electively. There's some debate about asymptomatic hernias. And there's one more thing we should say about these gastric volvulus, which is, again, the twisting of the stomach in the chest. That can happen in two types. Those are often called organoaxial and mesoaxial or mesenteroaxial. So I'll try to draw my stomach again. So you can imagine it's all in the name here. So organoaxial, you can think that the stomach is the axis of rotation. So the way to think about that is the axis is something like this. And the stomach actually rotates around itself this way. Think about if you're holding a towel in both your hands, one end of the towel would be here, the other end of the towel would be here, and you kind of spin it on itself and it wraps up. That would be the organoaxial volvulus. Whereas a mesentero or mesoaxial volvulus then you can think about where the stomach rotates essentially this way, and the axis is more along you can think of it as the mesentery of the stomach. So I think about it where I kind of imagine that with the herniation, the outlet and inlet of the stomach have come relatively close together, and you get kind of a twisting this way. I apologize, it's kind of hard to draw these things, so if you just Google a picture, that should hopefully give you some clarity. All right, so once we've decided we need to repair one of these, you have your basic tenets of repair. We're just going to kind of breeze through these. I just want you to get the broad concepts here. So first, we have to put everything back where it goes. And that's kind of these first three steps here, where we reduce the hernia and the hernia sac. We mobilize the esophagus. So remember, it was slid up in the chest. We want it down back in its normal location. And then we close those crura back up that got all stretched out by the stomach. Remember, the crura or the crus, those are those muscular bands that make up the esophageal hiatus and run on either side of the esophagus. So that's all about putting everything back where it goes. And then we want to prevent this from happening again. And that's typically done through an anti-reflux procedure, typically a fundoplication. We'll talk about that on the next slide. And then also some intra-abdominal fixation. So again, we have a hernia. We got to repair this. So step one is put everything back where it goes. So we're going to reduce the stomach and all these hernia contents back into the abdominal cavity. This is going to require us to mobilize the esophagus because it's usually adhesed up here. We want to make sure we get enough esophageal length to get it all the way down here so we can put that, have a tension-free repair, put the esophagus back where it belongs. We're going to do a crural closure. So these bands of tissue are the two crus, and you can see they get stretched out by the stomach being in a bad position. So they're going to need to be closed back together. Very rarely, they need to be supported with some mesh if you can't get them back together, but that's another controversial topic. Then once we have everything back in place, we have, again, our prevention steps: anti-reflux, fundoplications, and intra-abdominal fixation. The fixation is usually just a suture, excuse me, a suture gastropexy of the stomach to the anterior abdominal wall, or rarely some surgeons use G-tubes, usually 2 G-tubes, to prevent recurrent volvulus to do that fixation. So the last thing, I just wanted to talk about the different types of anti-reflux procedures or fundoplications, because they can be used both in this procedure and in some others, so it's good to be familiar with some of this terminology. First, let's talk about fundoplications. So fundo just means fundus. Remember, that's this part of the stomach right here. And then plication just means folding. And we have two reasons for doing these anti-reflux procedures. One, remember that a lot of these patients' symptoms are GERD, so this prevents further postoperative reflux, and also may minimize recurrence, because you can imagine if this is your normal stomach, once we do some of these plication procedures or fundoplications, we have this big bulky thing up by the esophageal hiatus, which will have a harder time herniating back up into the chest. And so these are probably the most common types of fundoplications that you will need to know. So there's the Nissen, that's your 360-degree wrap. So you can imagine you take essentially the fundus of the stomach and wrap it around both sides. So this is the fundus. You wrap it around both sides to meet itself and suture it together. You can do a Toupet, which is like a Nissen, but not all the way around, which is more of a 270-degree wrap. Again, you take that fundus, wrap it around each side, but you just don't bring it all the way together in the front. And then finally, there's a door fundoplication, not spelled the same, but I like to think of this as like closing a door. You're essentially just taking the fundus here and just folding it in front of the esophagus there. And these three different fundoplications, you can imagine that the 360-degree wrap is kind of the tightest, so it's going to be the best at preventing reflux and excuse me, regurgitation, but you have the most risk of having postoperative dysphagia while there's swelling, right? So the tighter this wrap is, the harder it's going to be for stuff to reflux up, but also it can potentially be hard for patients to swallow food. So especially if they have poor esophageal motility, you might lean towards either doing a Toupet, which is going to be somewhere in the middle, or a door, which is going to be the least tight of the wrap. So it's going to have the most potential for recurrent reflux, but the least likely to cause problems with swallowing or dysphagia. And of course, a Toupet is somewhere in the middle. Finally, one last thing to talk about is we talked about you have to mobilize the esophagus enough to do one of these fundoplications. And so what if you can't do this? What if the esophagus is stuck up in the chest so high that you're not able to bring it down to its normal position within the diaphragm? And if that's the case, you have to do what's called a Collis Gastroplasty. That involves essentially stapling across the stomach, something like this. And then you have this segment of the fundus now mobile to wrap around and perform your fundoplication. That's a little bit of a more advanced topic, but if you hear those terms, Collis Gastroplasty, or you have issues with or if you hear about people having issues with esophageal length, that is the usual mode to deal with that. All right, so that video went a little bit long, but hopefully it was still helpful. Remember, these are for teaching purposes only. Do not use them to diagnose or treat any diseases. We'll see you next time.